We're just going over some numbers, and I'm happy to report that we have started reporting our current COVID numbers on our intranet every day, so you'll be able to check and see the volumes coming to our hospitals. So the current surge, as you've heard over the news, and it's everywhere, we've made a lot of changes to accommodate the surge. And real briefly, we have activated 20 critical care beds. We've activated True North as a tele unit for our oncology patients. We've converted PACU bays and made them into 6 ICU beds. We've dedicated the entire West Tower to be a COVID tower. Our second floor now, second floor East Tower, is entirely dedicated to COVID. Both tents in emergency room are activated. We are administering monoclonal antibody in the emergency room, and that's helped prevent patients eventually getting more sick and coming as inpatients. So 61 such patients have been treated. Our supplies, PPE and reagents, beds and pharmaceuticals are in very good shape. Our employee well-being and spiritual support is in place. We have to say that our exposure and outbreaks have been very minimal. We've added additional intensivist shifts to help with our intensive care physicians. We're deploying about 50 additional travelers. 9 have already arrived. We started rescheduling all elective inpatient surgical cases and procedures that require beds. So this will allow us more capacity. We are not accepting any COVID positive patients through the transfer center. And yay, today we started the vaccination process. And I know that many of you may have already been in the auditorium, so we'll talk more about that. So just giving you a sense of our management of our COVID surge. Next, I'd like to introduce Dr. Maslow, who will spend a few minutes educating us on the vaccine.
Good morning, everybody. Just want to start out by thanking all of you from the bottom of my heart. I know what you're going through. I know how you're feeling. I know the stress. And there isn't one of us, doctor, nurse, anybody, administrator, we are under stress. So big breath. I'm going to present you the very good news right now. Take a breath, kick back. Here we go with the vaccine. We're going to take 2 seconds just to show who is the enemy, as if we don't know. This is Mr. COVID-19. You see the molecule on there are the spike proteins in red. Those are bad. They go into our respiratory tract, they attach to our endothelial cells, they go right for the ACE2 receptors, they find their way into the cells, and then they just go to town, replicating, going to every organ of our body, our brains, our vessels, our kidneys, our liver, our mind, just totally undermine our body and our well-being. Eventually, especially if we're lucky, we get this spike protein, and the whole COVID goes to what looks like a fried egg over there. It's a macrophage, and on its tentacles, it presents the SARS virus with the spike protein to our immune system. Our immune system then makes neutralizing antibodies, which can be measured. So when we get our IgG, that's what we measure. But what we don't know yet, it also triggers our T cell and B cell memory cells. So how much protection will that give us, and for how long? This we do not know. So different kinds of vaccines are available. There's 2 mRNA ones. They are the Pfizer, which is here in our auditorium, in my arm yesterday. I'm fine. We're fine. We went first because we wanted to, practice what we preach and assure you that we're safe. So how does it work? The mRNA vaccine is not COVID.
What it is, if I can advance the slide. What it is an analog. It's a nucleotide that has been made from the actual DNA of the COVID. There are other vaccines that are non-mRNA, but the two that are coming first and have so far been most effective are the Pfizer and the Moderna. Those are equivalent in efficacy. Those are safe. There's just a whole lot of conspiracy theory and fear and attention and terror. And what I want to get through is, to the best of my ability today, is that we've got to get past that. It's nonsense, truly nonsense. The other vaccines, the AstraZeneca is an adenovirus, which is more of a traditional platform. It's a monkey adenovirus, just a tiny bit. So it's not going to give you adenovirus, which is the common cold. And attached to that will be a little piece of the actual spike protein, not enough to give you COVID. And those are coming soon. The AstraZeneca is one, the Johnson & Johnson is another. Their efficacy, the AstraZeneca efficacy has been 70%, which is fantastic. Okay, I'm going to actually go back really quickly to this one. So here we go. This is like a nightmare for me. This is what I'm afraid of, this 9th grade, 10th grade biology. In the blue is the DNA. This is how it usually works in our body. The RNA is messenger RNA. Remember, DNA is in the nucleus. The messenger RNA is produced. It's a replica. Remember those horrible ACTG nucleotides. The messenger RNA makes a copy, goes outside of the nucleus, is a product of the genetic code in the DNA, goes out into the cytoplasm, finds a nice ribosome, and starts translating proteins. There you go. There is the usual way that we make proteins to make stuff in our body. So this was the most genius idea. If you ask me, the DNA from the COVID was sequenced in Wuhan, China, and released to the World Health Organization on January 10th, 2020, so that we could make a vaccine. What they were able to get was the sequence of mRNA, which is the instructions to basically fake your immune system with your consent into making a spike protein, which is so similar to the spike protein from the actual COVID that it induces immunity. It induces those measurable neutralizing antibodies and the memory cells, to the point that when a COVID comes near us, we may still get colonized with it, but we will not get sick. This is what's in your vaccine. This is the part that's scary, and I understand, and I needed to study this back to the 9th grade level to reassure myself that this is not something sketch. I don't think it's sketch. This is mRNA that instructs cells to produce a SARS-CoV-2-like protein. Please note, it cannot make the real deal. It's not live, it's not inactivated, it's not attenuated. It's a takeoff, it's a pseudo, it's fake. It is encapsulated in a lipid coat so that it will go into our cells. Then you're going to get a little potassium, just a little. You're going to get sodium, and you're going to get sucrose, which is sugar. That's all you're going to get. You're not going to get any kind of alteration to your genome, because mRNA cannot go backwards into the DNA. So your DNA stays your DNA. So we're past phase 3. We're in emergency use authorization. We don't have actual FDA approval yet. They're finishing up the studies to meet their endpoint, but more importantly, with 150 trials and they've invested millions and billions. They can't enroll other people if we approve any. So think about it, that it may not be not FDA approved for safety reasons. It may be more, they want to give all the other contenders a chance. Who gets it first? Thank God, us. Thank God, frontline workers, and also the nursing home residents and their caretakers. Along with frontline workers, ICU and emergency room, we also have our first responders, our paramedics, and we'll get into this a little bit. Liz is going to talk about this a little bit. Okay, I can really speak to this today. So I had my vaccine yesterday, and I've been saying that 50% are supposed to get chills, fever, headache, joint pain, and it's going to get a little bit, it says reactions attenuated in repeat vaccine. They're actually finding that it may be a little worse. I expected to be sick today. I even thought, how do I get in the door if I have a fever? My arm feels a little sore. I don't need any Tylenol. I feel fine. I don't feel any symptoms. But let me tell you, if I did feel symptoms, even bad symptoms, I would be thinking, it worked. Thank God. I would also be thinking, I don't need to worry that I just caught COVID and how bad is this going to get? And am I going to have respiratory failure or clots? None of that will happen. If you have symptoms, you're okay. You didn't get virus. It's just your immune system thinking you did. Take a little ibuprofen, take a little bit of Tylenol. If you feel really bad, of course, rest. We don't want anyone to come to work feeling lousy. But my point is, don't be afraid. Okay, so almost done with the slides. And this just means that they looked at 44,000 participants. Everyone was blinded. They gave placebo to half, and they gave Pfizer vaccine to half. They didn't know who was who. When they unblinded, they found that the disease only occurred in 10% that had gotten the vaccine. 90% of the disease was in those who had gotten the placebo. If that doesn't tell you that this thing works, and then the next day they looked at more data that had come, and it was 95%, actually 94.7, and that is just the same as Moderna. So we'll just skip over this. This showed that we don't have enough vaccinations, but we have gotten more than we thought we were going to have, so there will be enough for everybody. It needs to be cold, we know this. So what's the difference between Pfizer and Moderna? Pfizer needs to be kept colder. Moderna needs to be -4. It's sort of technical. Thanks to this great staff, we've got it all worked out. We're getting our allotment this time by way of Kaiser, I believe, and it's been sent to 11 hospitals in the vicinity, and we've got this down. You may wonder about, what if I get Guillain-Barré? What if I get transverse myelitis? So Guillain-Barré is actually more likely to happen with any virus, including COVID. There has been, it can cause Guillain-Barré. I personally haven't heard of any. There was one case of transverse myelitis, but not with the mRNA. That one was with AstraZeneca, and it was in the vaccine arm. It was not, I got this confirmed, it was not in the placebo. So that's why it was on hold. You might remember it was on hold. The reason that Johnson & Johnson, again, the adenovirus, the reason Johnson & Johnson was on hold for a while was because one of the I could be wrong. One of the participants came down with and was diagnosed with multiple sclerosis. It turned out that this person had it, was asymptomatic, and of course they didn't require getting a head CT to enter the study. So it was just one of those things. But when you think about it, thank goodness that they took it seriously. They lost the race in being first, but they did the right thing to protect us.
And so that pretty much concludes that part. We do have specific CDC vaccine recommendations. I don't know how I'm doing for time, so we might want to take these in the form of questions. But these came out on December 12th, which was Saturday, and I really want to, in some form, go through these with you, at least to alleviate any fears. Very, very much reassuring that unless you have had a anaphylactic allergic response to a previous vaccine, you can basically have this. Thank you. Okay, so in 5 minutes, I wish we could do questions. I wish that was a possibility, but what I'll do, so I'll go quickly and then just try and hit the major points. If I can hit it. Oh, yeah, you told me before. So as you know, for Pfizer, it's two shots. They need to be 21 days apart. Does it have to be absolutely exact? No, I forget everything. I'll try to be there on time. We've been through that. Try not to get it within 14 days of other vaccines. Won't hurt you. It won't hurt you. It's just we're trying to stick to what we've studied. Okay, so here's something of debate. So what if I've had COVID and I've tested positive? Should I get the vaccine? Yes, get the vaccine, and I'll tell you why. Because the antibodies from the vaccine are better than if you had the virus. This is so unlike what we've ever seen before. Remember all those chickenpox parties and the natural immunity was better than anything? That's a bad idea here. You don't get good immunity. You can get long hauler syndrome or worse. Now, how long? Oh, well, first of all, what if I don't know if I've had COVID? Do I need to get tested, IgM, IgG? No, you do not. And also, well, what if I know I've had it? How long do I need to wait? I've heard 90 days. No, they shorten that. Basically, let's say that I come down with COVID today. I would need to wait 10 days, which is the CDC clinical guideline. And if I'm not having a fever without Tylenol or Motrin between days 9 and 10, I can have my vaccine on day 11. Why did they initially say that you could not have the vaccine if you've had COVID? That's because we thought we were going to have a shortage. It can't hurt you. It's not going to make your immune system go bananas. And that's what this says. So we don't know enough to see, can I wait? Can I wait 90 days? Sure. We haven't seen much reinfection within 90 days. So if you're nervous and you want to see how other people are doing and you want to wait, perfect. Okay, so that covers that. We will talk about this as our last thing. If you have underlying medical conditions, you are the most vulnerable to catching COVID. Please get your vaccines. Now, if you're immunocompromised, what are they saying about that? Basically, they want to cover themselves because immunocompromised people were not included in the study. We know as good researchers that we can't generalize. So what we're saying is please talk to your physician. If you have an autoimmune disease, talk to your rheumatologist. Whoever is prescribing your medications, talk to your oncologist. Have that talk with them and just see, risk benefits. The beauty of this is it's not a live vaccine. So if you're immunocompromised, it can't give you COVID like some of our other vaccines that are live or live attenuated. Pregnant women, you have to have that talk with your OB and just come to a risk benefit. The only reason is they didn't study pregnant women. They're studying them now. They can't speak to that. It does not go into breast milk. It can't go into breast milk. So if you're breastfeeding, by all means, go ahead and get your vaccine. And
Remember, it doesn't affect your DNA. So if you're pregnant, it's not going to change your baby. Anyway, we've already talked about who should get it. I personally am very allergic to penicillin. I'm allergic to fish. I've been in the ER. You know, I haven't had a reaction to a vaccine. I took it yesterday. You don't need to worry about this. You don't need to worry if you're allergic to foods, soaps. It's just related to vaccine. You don't need to prophylax. It is going to protect you 95%. When? Well, by 2 weeks after getting it, you should be 50% immune. Still, that's not good enough. You need to get the shot. I need to remember to get my second shot. 3 weeks, so 21 days, and then it's estimated that 7 days after my second shot, 1 month after my first shot, I will be as immune to this as I will be to measles. And anyway, we've already said you can still be colonized. You can still be colonized. You might give it to somebody inadvertently, so you still need to keep your safe six, if you will, and practice safe six. And you need to wear your mask. And we will, that's what I just talked about. And thank you, go get your shot, make it a double. Happy holidays.
Thank you very much, Dr. Maslow. There were several questions posted that I believe you all answered them all in your presentation, but we will do more formal answer to those questions and post them on internet. And now I would like to introduce Liz Cochran, our Chief Operating Officer, who will share with us the deployment process of getting the vaccines, and she will try to answer some of your questions that you've raised on this topic.
Thank you, Dr. Maslow. Thank you, Elise. So good morning, everyone. I'm sure if you haven't already heard, the vaccine is here. And as such, we have started to vaccinate those that are in our highest risk category. But I want to spend a minute just quickly letting you know how many doses we have and a little bit more about what's to come. So we have received approximately 1,700, a little bit more than that, of our Pfizer doses. We are also going to be getting Moderna next week. I don't know exactly what day, but after the 21st, which is Monday, we'll be receiving another 1,200 doses of Moderna. That's great news because the 1,700 doses that we have are for the highest risk and high category. And those are those individuals that work directly with COVID patients in the units. So once we've gone through that group, we'll start very quickly on the high risk and the moderate risk, which I think by next week we'll have been able to give dates for that. But due to the limited supply to meet the demand, the approach is phased with priority groups. So that communication of who that is went out yesterday, went to the physicians and went to the staff. And so in some departments, you're going to see that your staff actually is going and some staff isn't. And that's because in some departments, and I'll just use an example, physical therapy, they have quite a bit of people in outpatient that work in the unit, but they also have staff who work in the inpatient unit. So those who go first would be those in the inpatient, and then later on in the week, we would do the outpatient. That's just one example. So you'll be scheduled for that vaccine through your department director. I want you to know that. When you show up, you'll be on a list of which you'll be checking in. And then from there, we'll get the information we need because it's a very rigorous and detailed process. We need to collect information that the state and county and federal government is asking of us, but it's really to make sure that we collect all the right information and pass it on so we keep very tight controls of what's happening. And then what we're going to do is ask that you stay in tune for the new announcement next week. We may get it out sooner depending on how fast we get through the next few days. There may be, will we start maybe Monday, maybe Tuesday, but we'll be starting the new vaccine phase as soon as we get through the first group. Next slide. Okay, so who's in the first group? Staff and physicians at highest risk of exposure through their work in any direct healthcare area. It says IE because what's missing there was the groups at ICU, ED, people in surgery, procedure areas, and those who work directly in the rooms themselves. And that includes some of our EBS staff, our transportation staff, certainly respiratory therapy, So that's the group we're talking about. Then it includes that we would then even add more, and that's the list that I was mentioning. There are some departments like physical therapy, registration staff, lab staff, phlebotomists in particular, things like imaging. Those individuals would also be, and they are on this list. OBs in this list, you know, taking care of mothers and babies. But mostly it's because we're getting a lot of patients coming through the area with COVID. It's pretty widespread at this point. The next phase, which was what I was referring to for next week on the 21st, we will start going ahead and giving notice to the employees who are in the subsequent groups, including our outpatient facility staff, home health, and hospice care. So those are the immediate groups that we'll be looking at. I want to answer a couple questions that were provided by some of you, so we can get through these very quickly. First question is if after receiving the vaccine we experience fever, fatigue, and need to take 1 or more days off for recovery, does this come out of our COVID pay or out of our paid leave? I'm going to leave that for HR to respond to perhaps later through Dan, because I'm not sure if that's been determined yet, because as Dr. Maslow has already said, most of people that get the shot experience very little side effects, and if they do, they usually go away within 24 hours, and it might be soreness, it could be a little fever, but it generally goes away fairly quickly. The next is, will there be a priority to family members of hospital employees? At this point, no, because we don't have enough, but in the future, should we have enough to do something where we can help out, we would do that to the community as well. I don't have an answer for that, but today I will say no. Will associates have the option to choose to receive Moderna versus Pfizer? The answer is no. And I think Dr. Maslow touched on it. If you started with a Pfizer dose, which is what we have today, you have to finish your second dose that's Pfizer. If it's Moderna, which would then become available, it would have to finish with Moderna. So it's not a choice. And as Dr. Maslow has also said, they're really the same. I did learn today one more little piece of information, and that is Pfizer allows those who are 16, as young as 16 years old, to get the Pfizer dose. Moderna you have to be 18. That's really the only difference besides the temperature change difference of refrigeration. And then the last question is, at what stage in the process will we be offering it to people over 65 with 2 or more medical conditions? So we're offering it once again to all the hospital staff and those in the clinic areas. We believe that touches everyone. So if you're 65 and older and you have comorbidities yourself, you would be included and you would be able to get the vaccination. If we're referring to those in your family and others, we don't have an answer for that yet, because we don't know if we're going to have enough allotment in the future. Our understanding is as this rolls out throughout the nation, we'll be steadily getting more and more, and as we do, we'll be communicating what we'll be doing and who we can offer it to.
Thank you, Liz. Today's session has been recorded and will be posted on one channel later today. If you wish to take another look, and there were questions you had that we went over really fast, to be able to hopefully get your answers. Again, thank you for your time. Stay healthy. Happy holidays to you and your families. We're blessed to have you all as part of our family.